Cardiogenic shock is based upon an inadequate circulation of blood due to primary failure of the ventricles of the heart to function effectively. As this is a type of circulatory shock, there is insufficient perfusion of tissue to meet the required demands for oxygen and nutrients. Cardiogenic shock is a largely irreversible condition and as such is more often fatal than not. The condition involves increasingly more pervasive cell death from oxygen starvation and nutrient starvation. Because of this, it may lead to cardiac arrest, which is an acute cessation of cardiac pump function. Cardiogenic shock is defined by sustained hypertension with tissue hypoperfusion despite adequate left ventricular filling pressure. Signs of tissue hypoperfusion include oliguria, cool extremities, and altered level of consciousness. Signs and symptoms: anxiety, restlessness, altered mental state due to decreased cerebral perfusion and subsequent hypoxia. Hypertension due to decrease in cardiac output. A rapid, weak, thready pulse due to decreased circulation combined with tachycardia. Cool, clammy, and mottled skin, due to vasoconstriction and subsequent hypoperfusion of the skin. Distended jugular veins due to increased jugular venous pressure. Oliguria due to insufficient renal perfusion if condition persists. Rapid and deeper respirations due to sympathetic nervous system stimulation and acidosis. Fatigue due to hyperventilation and hypoxia. Absent pulse in tachyarrhythmia. Pulmonary edema, involving fluid backup in the lungs due to insufficient pumping of the heart. Causes: cardiogenic shock is caused by the failure of the heart to pump effectively. It can be due to damage to the heart muscle, most often from a large myocardial infarction. Other causes include arrhythmia, cardiomyopathy, cardiac valve problems, ventricular outflow obstruction in hypertrophic cardiomyopathy, or ventricular septal defects. It can also be caused by a sudden decompressurization, where air bubbles are released into the bloodstream, causing heart failure. Diagnosis: electrocardiogram. An electrocardiogram helps establishing the exact diagnosis and guides treatment. It may reveal cardiac arrhythmias, myocardial infarction, signs of cardiomyopathy. Ultrasound, echocardiography may show poor ventricular function, signs of PED, ventricular septal rupture, and obstructed outflow tract or cardiomyopathy. Swan-Ganz catheter. The Swan-Ganz catheter or pulmonary artery catheter may assist in the diagnosis by providing information on the hemodynamics. Biopsy: in case of suspected cardiomyopathy, a biopsy of heart muscle may be needed to make a definite diagnosis. But biopsy should only be done when third space is suspected. Treatment: in cardiogenic shock, depending on the type of myocardial infarction, treatment involves infusion of fluids, or in shock refractory to fluids, inotropic medications. In case of cardiac arrhythmia, several antiarrhythmic agents may be administered, that is adenosine, verapamil, amiodarone, I2 blocker or glucagon. Positive inotropic agents, which enhance the heart's pumping capabilities, are used to improve the contractility and correct the hypertension. Should that not suffice, an intra-aortic balloon pump can be considered or a left ventricular assist device. Finally, as a last resort, if the patient can be made stable enough and otherwise qualifies, cardiac transplantation can be performed. These invasive measures are important tools. More than 50% of patients who do not die immediately due to cardiac arrest from a lethal arrhythmia and live to reach the hospital, die within the first 24 hours. The mortality rate for those still living at time of admission who suffer complications from cardiogenic shock is even worse, around 85%, especially without drastic measures such as ventricular assist devices or transplantation. Cardiogenic shock may be treated with intravenous dobutamine, which acts on I2 receptors of the heart, leading to increased contractility and heart rate. References. External links: Cardiogenic shock by eMedicine.